Good morning, good morning. Good morning, good morning. We are excited to have you right here at Berean Christian Church, Gwinnett. My name is Deacon David Cuffey. I serve as the Director of Church Ministries. We are so excited to have this joint collaborative between Berean Christian Church, Gwinnett, and Hill Collaborative to bless our community with a community conversation on colorectal cancer. Again, a community conversation. The fact that we're here this morning. Now, we couldn't do this without our phenomenal shepherd of this house, Dr. Kevin B. Lee. So would you join me in a big welcome for Dr. Kevin B. Lee, Senior Pastor of Berean Christian Church, Gwinnett.
Somebody say heal. 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 Now, am I talking about H-I-L-L or H-E-A-L? H-E-A-L. Sometimes they say heal, H-I-L-L, to get your healing, H-E-A-L. But we're here today, thank God for this collaborative effort to hear from this organization about how we can be healed and stay healed. We just read that God wants us to prosper. 1 Thessalonians 5:23. In our what? Spirit, soul, and body. And we're here today to give some information how we can prosper in our body. Thank God that the Holy Spirit drives us, helps us with our soul, our emotions, and our will to get the information we need, hallelujah, so we can experience life. Does anybody know as I get ready to leave y'all, because I got to speak somewhere else, and I'm going to hold on to this information. The Bible verse, I'm out of here. What do I have? That's a $20 bill, that's too much. What's the Bible verse that we're learning in our church this year? We're learning 2 Bible verses, but there's one. What does it say? John 10:10. How might help me with it? But I have come. Where's that found? Don't forget that, y'all. Steal, kill, destroy. That's what the devil wants to do. But he has come that we can have life and have it more abundantly. And that's what we're about to do today. Forgive us for our air conditioning is going out. It's about $15,000 to $20,000 to get it fixed. And so we're going to take a love offering as soon as this is over. Hallelujah. But no, right now, y'all, hopefully in the next 7 to 10 days, they'll have it fixed. So forgive us with the hair. It's on its way. Love you. Appreciate you. Thank you for being here. Thank you, Deacon Duffy.
We're so grateful to have a senior pastor who really is committed to allowing us to be a community agent for Berean Gwinnett, to be a beacon of light. And that goes without saying. It is a pleasure to prepare to welcome our next guest speaker, who it goes without saying he is well known. He is a distinguished man of God. He is a national director for our faith-based initiative, Hill Collaborative. But most importantly, he is a servant of the Lord. Y'all give it up for Deacon Reverend, I'm just kidding, Deacon Stan Watson, brothers.
I don't know who you're talking about. Let's go get this thing on the road. Good afternoon. My name is Stan Watson. I bring you greetings from the House of Hope Church, where my pastor is Dewey Smith. I am the National Director for Hill Collaborative. This organization has done a lot across the country to make sure that we have equity in our health care around the country. Where there has been a lack or a void, we have been out in the hedges and byways to make sure that they become filled. Our job is to make sure that we bring information to our community, especially the African American community, about health benefits, about pharmacy benefits, about all the things that we generally don't have in our African American community, with colorectal cancer, with chronic kidney disease, with dementia and those things. We have a summit every year on chronic kidney disease around the country. So our organization has been one that's been pleasured to work with churches and schools to make sure that we get our information in our community so you can spread the word about the things that we need to do about health care. We all know what's going on in Washington. We know that our benefits are being cut. We know that even at the state level that our benefits are being cut. Here in Georgia, we know about the uninsured. We know about the Medicaid benefits that we don't have. And we know the uninsured rolls are tremendous across the country. We know that tobacco settlements are being escaped us right now around the country, especially in places like Tennessee, Georgia, and Kentucky. So we have to do a lot to do that. So we're here today to do colorectal cancer. You were talking about men a few minutes ago about the spirit and the soul. Well, we're here to talk about the body. One of the things that I think that men have to understand, I'm glad the women are here too, is that this body has an expiration date on it. It's just like going to your cabinet and looking at your food, and you look at the expiration date. At some point, this body says, I have to go. But you can extend the expiration date by looking at the date, and those things that are not good for your body, you try to get them out of your body, and you try to make those things become prevalent for you by doing the right things. Those things are getting your health checked. Those things that make sure that you become part of clinical trials. Oftentimes, we don't even want to do clinical trials because we say that those things are not important for African Americans. But how do we know that medicine will affect us if we don't ever have a chance to take it? When we don't have the wherewithal to go to clinical trials. So we try to make sure that as a group from HEAL that we talk to you about clinical trials as well. Well, today we have some great speakers. Our moderator is a great moderator because he's a colorectal cancer doctor. And so we're going to make sure that we get the information to you today. We're going to do it concise. We're going to, I guess he's going to make sure that we adhere to Robert Rules of Order. Those questions that we don't get to, we ask that you put them on your card. Again, this is sponsored by HEAL in conjunction with Berean Christian Church. We welcome you this morning for this presentation. I'm going to present to you right now our moderator, Dr. Wayne Tuxton.
Good morning to you all. We're going to have a quick announcement from Tara in a minute because there's you all have some programs. You have a survey to fill out. You'll notice it has 2 pages. One that's a pre, and then there's a post portion to the survey. We want to make sure that you fill it out. Tara, why don't you come and explain about the survey? This is Ms. Tara Handy, who has set up this program today. Thank you very much, Tara.
Good morning, everybody. So in order for HEAL to bring you the information and education on the topics that you want to hear about, it's important for you to fill out the surveys so that we can take that information and bring it back to the community. So if you look in your folder, pull out your survey, the part that says pre-survey, go ahead and fill that out right now. And then towards the end, I'm going to come back and we're going to do the other side of that form. And if you don't have a survey, please let me know. I'll get that for you.
All right, thank you very much, Tara. Thank you. Please do make sure you fill out those programs. And it is good to see so many people out here today. One of the things Stan said, we all have an expiration date, and that's true. We're all going to die. We know that. Of course, we know one of the congresswoman said that everybody's going to die, and she said in a very callous manner. But the idea, when we talk about health care, is that we know we're going to die, but we're going to die as late in life and as healthy as we possibly can. And that's the whole idea behind public health. And some of the messages we're going to talk about today are directed toward that. Just out of curiosity, how many of you made a conscious decision about what you're going to wear today? Okay, good. How many of you made a conscious decision on how you're going to style your hair? Now, I'm not going to call on some of the brothers because some got more down here than they got up there. But that's okay. That's all right. We ain't going to talk about that. Why. I heard a congressman one time say, why waste good hormones growing hair? And I think he may be right. How many of you made a conscious decision and can tell me when you last had a haircut or went to a place to get your hair styled? All right. Now, how many of you can tell me what your stool looked like, the color and or shape? Very good. It's funny. More women than men. Why don't you look? What are you afraid of? It ain't going to bite you. It's already in the toilet. You done drowned the darn thing. Take a look back there. It's important. Today we're going to have a community conversation on colon cancer. We're going to talk about what colon cancer is, the impact it has in our community, some of the things that lead to the development of colon cancer, some of the things we can do to help us stave off the development of colon cancer. And then we're going to talk about other things that we can do to try to keep us alive when we're talking about colon cancer. And as Stan had said, we have the opportunity to have several good speakers. We're going to talk about screening. We're going to talk about what the disease is. And then as you saw the food that's out there, we're going to talk about how we can cook things. Now, I don't mean cooking it to kill all the good nutrients and everything that's in there. How many of y'all cook greens for 4 hours? Yeah, raise your hand. Come on. You know, good. One sister that doesn't do that. Yeah. Why do we do that to the Greens ain't got nothing against us. They ain't bite us. They ain't do nothing. We need to look at how we're going to keep food health, how we can still maintain and eat things and maintain the nutrients and yet still maintain our ethnic culinary history. And that's what we're going to talk about today. Our first speaker is Dr. Erin King Mullins. She's a colon rectal surgeon who's currently practicing in Fayette, Georgia. She completed her undergraduate degree at Xavier University in New Orleans, followed by going to medical school at Emory over there in Atlanta, and did a surgical residency at the Orlando Regional Medical Center. She did a fellowship in colon and rectal surgery with the Georgia Colon and Rectal Surgery Associates, with whom she used to be partnered. She is now the founding member and president-elect of something called Society of Black Colon and Rectal Surgeons. She was featured on the Today Show for something which she had called the Corona Mama's Blog. Now, see, at the time, Dr. Mullins was pregnant when the COVID was rampant, and so she had her baby. And she realized that there were a lot of women undergoing postpartum conditions, questioning things, in particular looking at racial injustice during COVID. So she started this blog, and because of this, the Today Show found out about, I don't know how they found, well, of course I know how they found out about you. Can't help but find out about it. Anyway, so she was featured on the Today Show talking about that. She's now in practice at the Colorectal Wellness Center in Fayette, Georgia, and she'll be speaking to us about the changing demographics in colon and rectal surgery. Dr. Mullins. And she has a very fancy boot on if you wonder why she's walking. Sorry. Sorry. I think she hurt her leg.
Good morning. Thank you so much for that warm introduction. So I want to thank Wayne so much for inviting me to be a part of this event. He's been a mentor to me over the past several years. I met him during COVID. Essentially from afar. He was introduced to me by one of our former presidents of our national colorectal organization when we were facing a lot of the social injustices and especially surrounding healthcare. And so we worked together to help form the first DEI task force for our national colorectal organization. So thank you, Wayne, so much for being such an important part of my continued development and growth. Do we have my slides ready? So actually, before we really progress, can I get a show of hands of those who have ever heard of a colorectal surgeon? Okay, good, because I didn't know what a colorectal surgeon was until I started residency, so y'all are light years ahead of me. So we're going to talk a little bit about colorectal cancer in the Black population, but we obviously always have to start at the foundation. We always have to start at, kind of what is this conversation, what is colorectal cancer in general. Show of hands, anybody in the room who has had any sort of colon cancer screening test. So whether it be a colonoscopy or some of the stool examinations and things like that. Great. And so are you having conversations about those results with your family members? Okay, so and we'll talk about the importance of that as well. Next slide. So this is a lot of times what people think, the face of colorectal cancer is, right? Historically, they think it's, the older generation. They think certain demographics. An old white man is usually, what historically folks thought who was, getting colorectal cancer. Next slide. This is the current face of colorectal cancer, okay? It knows no race. It knows no age. It knows no financial status. It doesn't know any of that, okay? There's an important, next slide. So what we'll go through today is a little bit of some of the statistics, what is a polyp, what is cancer, some of the symptoms, the screening, the risk factors, and kind of what are some of the hurdles that we're facing and how we can some solutions that we can get through. Next slide. So right now, colorectal cancer is the third most commonly diagnosed cancer in both men and women in the United States. I can't tell you how many men and women come to my office, maybe a husband and wife. She dragged him in there to get his colonoscopy consultation, and I turned to her, have you had your colonoscopy? Well, I don't need it, I'm a woman. Says who? You have a colon? So women are just as affected. There's a slight male predominance, but it's not as big as you think. So women, we got to get our colonoscopies too. Colorectal cancer is the second leading cause of cancer-related deaths in the United States. Next slide. So the recommended screening age for colorectal cancer was 50 for a long time, and a lot of people are still holding on to that. And actually in 2021, the U.S. Preventive Services Task Force, long thing, they actually updated their recommendations to 45 for everyone. However, the recommendation had been for African Americans to start at 45 for several years prior to that. So we don't know if that number's going to change, but definitely it's been there for a long time. But this is an astounding statistic. By the year 2030, which is only 4.5 years from now, colorectal cancer will be the #1 cancer killer in persons under 50. Okay? So not diagnosed, death. Next slide. So African Americans, we're leading the pack, unfortunately. And we could talk about all the reasons why. And we all have to, #1, there's the health system side that obviously plays a role. And there's a us system side that plays a role. And so, there were studies that showed one of the #1 reasons that folks don't get a colonoscopy is that no one told them. Right? I can't assume, as with all the knowledge that I know and living in the colorectal space every day and seeing cancer patients every day, I can't assume that that's your everyday life. I can't assume that you've, ever been told or instructed or educated what colorectal cancer is or what screening is. So, there's a lot of assumptions on the physician side to think and assume that this is public knowledge. And that's also for us specialists, but also for primary care doctors. So there's also, the access that we always talk about, the disparities. But there's also the intimate conversations that we may or may not be having with each other, right? So all of you who raised your hands about colonoscopy, you may have told your loved ones that you had a colonoscopy, but what exactly did you tell them about it? So many people come to my office and they see me and I'm asking them, to understand what their level of risk is. And the #1 risk factor, by the way, is age, right? So 45, just like after a certain age, we start getting those mammograms and we start getting those prostates checked. Age is the #1 risk factor. Only about 10% to 15% of people who are diagnosed with colon cancer have a family history of it. So the overwhelming majority of it just happens. But again, getting back to those conversations about colonoscopies. So how many times people come to my office and I ask them, hey, is there any family history of colorectal cancer? And they say, nope, no cancer that we know about, right? And then I ask them about polyps. I'm like, you told me your mom, your dad, whoever had a colonoscopy, did they have polyps? Well, they said their colonoscopy was fine. What does fine mean? So yes, if you dig a little bit deeper and say, go back and talk to your parents or your siblings who said their colonoscopy was fine. So does fine mean that they looked inside and said they didn't take any biopsies, they didn't tell you to come back early, and they're like, oh no, yeah, they took off a couple of polyps, but they were fine. So that's now a family history, okay? So it's not about just a family history of colorectal cancer, it's a family history of polyps, because polyps are what eventually grow and turn into cancer. You see somebody with a mole on their face and over time it grows and starts looking funky and now it's like, okay, that's skin cancer. Same thing, that's how it starts inside the body. So a polyp is a precancerous condition. So we'll kind of get through, next slide. So a polyp is a precancerous condition, okay? So the best way to describe it is kind of like that mole that is growing on the inside lining of your colon. And so these are very small. there's a 30% increased risk in forming in a family history. If someone has a polyp, that increases the family history risk of about 30% to eventually having cancer, because again, that is part of the hereditary nature of this that contributes. So when we look inside the colon, we're looking for these polyps. We can remove them right then and there. So we see something, we can do something about it and prevent it from growing and turning into cancer. And we want to do this, and that's the premise, the concept behind screening. Screening means we're going to look before you have any symptoms. Because when you start having symptoms, that's called diagnostic. I'm trying to diagnose you with why things aren't right, why your stool isn't looking the way it should, why your stomach's hurting, why you're losing weight, why you're having blood. So screening means that you are not having any symptoms and it's just time to go look. And it may be earlier if you have that family history. But once a polyp reaches 1 centimeter in size, you know how big that is? 1 centimeter is less than half of an inch. Once a polyp reaches 1 centimeter in size, there is a 50-50 chance that it's cancerous. You're not going to feel that. That's not going to block off your intestines and cause bleeding and all that type of stuff. And so that's why we have to go in there and look. Next slide. So this is just kind of a depiction of what a polyp. You see how flat that is? So this is a cancer. This is flat. And so people get, they get frustrated, or one of the main reasons people don't want to get their colonoscopies. I don't want to take that prep. I don't want to, they'll be pooping all night and this and that, But again, how am I going to see something that's less than half of an inch inside unless you're cleaned out? Okay? So this is exactly why we have, to do that prep and make sure that we can see well. Next slide. So symptoms. So the number one symptom is no symptom, right? So we just talked about how small a cancer can be. And so there are lots of times early cancers that are identified on someone's first ever colonoscopy that was screening because it was just time. And so early detection means early treatment means longer longevity, life, and survival, okay? But some of the symptoms include changing in the bowels, so diarrhea, constipation, you feel like you've incompletely evacuated, you don't feel satisfied after that bowel movement, narrow stools, they can have blood, so bright red blood, or it could be super dark, because if it's coming from higher up in the colon as it's getting processed through the body, then it can have that really dark, coloration. Abdominal pain. Losing weight because you didn't necessarily try to lose weight, feeling fatigued, having nausea and vomiting. But, with those cluster of symptoms, that can mean several different things. So not only, can we not have symptoms, we can have very non-specific or subtle symptoms. And so one of the things that we're facing as well, as we're seeing more and more women being diagnosed with colorectal cancer, sometimes, unfortunately, some of their symptoms can be brushed off for a while, related to their menstruation or related to fibroids or cysts on their ovaries and things like that. So the important thing to know is, number one, the symptoms are not necessarily super specific to colorectal cancer, but if you have any of these things and they persist, they need to be evaluated. So if you're a normal go everyday person, using the restroom, and then all of a sudden things have changed, now, okay, if you traveled, you ate a bunch of cheese, you did something different and things got back right, okay. But if there's a persistent change that's lasting like more than 2 weeks, you need to not try to self-diagnose and self-treat and go down that aisle in CVS and say, oh, this is for abdominal pain, and this is for bloating, and this is Pepto-Bismol. Remember that old commercial, heartburn, upset stomach, diarrhea, they doing all that dance? Don't do that dance. Go see your doctor, okay? All right. So there's different options for screening. So we talk about invasive procedures, meaning, there's a procedure that's done. And then there's non-invasive. So our gold standard, our highest level, is that colonoscopy for multiple reasons. Number one, it's both diagnostic and therapeutic, meaning if I diagnose something like a small polyp, I can provide the therapy right then and there. I can remove that polyp, get rid of it. We send it to the lab. We know exactly what type it is, and that lets us know the next time you need one. But it's also important, again, as we mentioned, for family history. If we have to have siblings, children start earlier and more frequently. A flexible sigmoidoscopy is just a partial colonoscopy. You're looking at the end. And so some patients who are a little bit lower risk, but they may have some bleeding or symptoms, sometimes we just want to do that flexible sigmoidoscopy to see if there's a risk that they really need the full colonoscopy. But those are just the invasive procedures. So non-invasive procedures, so those stool tests. How many of you have heard of the Cologuard test? Okay. How many of you have seen, there's a commercial, there was a commercial that was released with Lil Jon and Cologuard? Okay. Anybody seen that? Okay. And then there's other tests. There's some x-rays and all those things that can be done. Those types of tests will also require the stool to prep. But those tests, if they come back abnormal, you got to turn around and get a colonoscopy anyway. So they don't. And then, if you get an X-ray that shows, oh, there may be a lump there or something like that, you don't know what it is. So now you got all this anxiety. You got this abnormal test. Now you got to call and now get scheduled for that colonoscopy. Super anxious that whole time to figure out, oh, do I really have cancer because that test came back abnormal. So that's one of the more important reasons to go ahead and get the colonoscopy. But also, as Stan alluded to, being in clinical trials and things like that, a lot of people don't know that the Cologuard test, number one, if you have a family history of colon cancer or polyps, you're not a candidate for that test because you're already high risk. So those are for average risk individuals. So your test is the colonoscopy. But second, what people don't know, and unfortunately nobody's going to advertise this, there were not enough Black people that were involved in the studies for Cologuard. So if you break down the subsector of patients that were African American, what we call a sensitivity, or in layman's term, the accuracy of that test goes down to 60-something% in the Black population because there were not enough of us in those studies for them to definitively say that it can detect a cancer in you. Okay, so they're gonna tout all day that, and I don't know if this may go public or whatever, and I'll probably get canceled, but whatever. I'm here to make sure y'all don't get canceled. Okay, so they're gonna throw out those numbers of 90-something% effectiveness. That's for the general population. So if you took everybody, whoever was involved in that study to take that test, you can make numbers say whatever you want them to say, right? And so when we got everybody together, it's 90-something%. So that sounds great. But when you look at the subset of the patients that look like us, now that's not to say that in the future it won't be good enough for us, but we don't know that because there were not enough of us represented in those studies. Okay, so get your colonoscopy. Next. So we talked about the benefits, early detection of the polyps, so you can remove them to stop them from turning into cancer, and again, reduce mortality. A stage 1 colorectal cancer has a greater than 90% cure rate. Once you go down to stage 3 and it's starting to spread to other places, we're down to 50-50, okay? Next. The most underrated screening tool is talking. I've said that over and over, okay? Because once someone in your family is diagnosed with a colorectal cancer or a polyp, people in that immediate vicinity are at higher risk, so they're gonna have to start getting tested earlier and more often, okay? So number one screening tool and that is free, okay? Next. So we got some risk factors. There's things that we can't modify: our age, our gender, our family history, the genes that were passed down to us, but we got some stuff we can do, okay? Modifiable risk factors. Your diet. Diets that are high in processed foods are very low in nutrients. Your colon literally gets its nutrition from the foods you eat. It extracts it from high fiber foods. And so having those probiotics and those high fiber diets are gonna be important. Activity. Just like you work out to feed your lungs and your heart, there's blood flow to your intestines. And so you gotta get that heart rate up to feed the intestines so it can get the nourishment that it needs as well. And we all know about smoking and alcohol. That's going to be obvious. Yep. Sorry. Next slide. So what are our hurdles? And so when we talk about those non-modifiable risk factors, knowing, what your opportunities are available to you. So through your insurance companies, knowing what preventative services are covered at what age and how often you can get those, how family history impacts you. Sometimes employers have different beneficial programs that they have perks for getting your different screenings and all of those things. And then, those who are at risk, a lot of these different organizations, the public health departments and things like that may help with access to these screening exams. So just know what's available to you. Other hurdles are obviously food insecurity, cost of nutrition, food, environment. If you're not necessarily living in a safe neighborhood, it might not be easy for you to get and walk outside. And so just knowing, what you can do to kind of keep your health up. And you're going to get the cooking demonstrations later to help you understand what you can do with the resources that you already have. Next. So, accessing your local resources, prepping your meals, you get the demo later, and taking advantage of any of those healthy lifestyle incentives through maybe some of your insurance companies and employers. Because, so a lot of times, depending on, especially if you work for a major company, sometimes you'll get these random emails about like log in for these perks and this and that, or through the, some of those things are really beneficial. They may have a free trial for something like that, HelloFresh or something like that. It's not necessarily something that you're going to keep doing forever, but when you go on to those meal plan programs and you pick out like, hey, I want a low calorie or high fiber meal, guess what? They're sending you the ingredients and they're sending you the recipes, and use that free trial to just kind of understand what the breakdown of those ingredients are, how you might be able to prepare them a little bit differently. So you don't have to continue paying for that meal service, but now you've been equipped with some tools, to kind of help do that. And so just make sure we're taking advantage of all of that. And like I said, just, talk. That's the cheapest way to understand what your risk is. Thank you.
We'll have a brief question and answer session after our next speaker. So please, if you have a question, write it down. If you think that you might not be able to remember it. So please do keep track of that if you think you might have one. Our next presentation is going to be on screening, talking about breast and prostate cancer, because these are also some very important cancers to talk about in our African American community. And our speaker is going to be Ms. Imanja Murray. Ms. Murray is the Comprehensive Cancer Program Manager of the Georgia Department of Health. And I should point out that she earned her degree in Public Relations, Advertising, and Applied Communication down at the Florida Agriculture Mechanical University. So I guess you must have had, well, and I guess, that's you?
Anyway.
If you can't go to the Mecca, I guess FAMU is good. I'm just saying. But anyway. Thank you very much, sir. Ms. Murray is also the CEO of Girls on the Rise, Inc., which is a program that's involved with that, and she's also involved in a program called Life Changers, Inc., which is an organization that works with justice-involved individuals who are transitioning back into society. More importantly, I thought it was kind of interesting. Ms. Murray is the author of an article entitled How Setting Goals Help You Achieve Success. From that, there's one quote which I found very interesting, particularly as it relates to when we're talking about health and things that we can do for our health. And it is, when you set a goal, you commit to working toward it, encouraging responsibility and self-discipline. This is one of the most important things we can do when we talk about how can we keep ourselves healthy. It's what can we do for ourselves. So to that end, to give us a presentation on screening with breast and prostate cancer in particular, give you Ms. Imanja Murray.
Thank you so much for that introduction. Okay, let me pull my screen up. I'm sorry, you guys. I don't have a PowerPoint for you guys. I do have some videos, but I won't hold you for too long. I'm sorry, let me grab my bag. Okay, so how was everyone doing this afternoon? Everyone doing good? Okay, so once again, I am Imandra Murray. I am the Comprehensive Cancer Program Manager with the Department of Public Health, and I'm so excited to be with you all this, afternoon. So today we're going to discuss the importance of cancer screenings, why they matter specifically in our communities, and how early action can literally save lives. So I want to engage with you guys and ask a few questions and see where your guys' heads are at. I want to know, what are some reasons people don't get screened for cancer? You said don't have time? All right, I got a gift for you, since you was the first one to, thank you, to respond. Said don't have time, what else? Scared. Okay. The doctor doesn't tell them, doesn't inform them. Just don't want to know. Uninsured. Distrust of medical field. Okay, all right, great. So I literally have this list. Literally everything that you said is the concerns, especially like I said, within our communities, right? So the first thing I want to just discuss is the medical mistrust. Do y'all remember the Tuskegee syphilis study? I think it was in like 1930. It started in like 1932. So it was a 40-year study, and it was 600 black men. 200 of them did not have syphilis. 400 of them did. And so, of course, those 200 was the control group. And so within this time frame, they eventually found the cure, which was penicillin, I think like 1947, but they weren't treating these men. And so these men were dying. These men, of course, they couldn't go anywhere else to get the treatment, and they were passing it along to their spouses and even to their children. And so you may not even know this, but that is kind of like a big part of why our community do not trust the medical system. So I'm going to get back into that, but I just wanted to address that one. Like you guys said, another one, the cost, the lack of access, correct? So I got to work. I have to provide for my family. I don't have time to go to the doctor's office. I can't afford to lose hours, or I may not even have transportation. I might have found a doctor's office, but I live in Clayton County, and it's all the way in DeKalb. I don't have a way to get over there. Like you guys said, the fear, stigma. It can also be the idea that I do feel this lump in my breast. But like I said, I'm the sole provider of my family. I can't worry about that right now. It'll go away. We have a tendency to sometimes just push it to the side and say, okay, maybe it'll just go away, and unfortunately that does happen. And then also it's the lack of awareness and information, just not knowing. A lot of people may feel like, I feel fine. I drink my water. I walk every day. There's no lumps on my breast. I don't have any issues, no symptoms. But like we all know, you may not have symptoms. And that's the beginning. So like we all know, cancer affects everyone. But research shows that African Americans, both men and women, are more likely to be diagnosed at later stages and have higher death rates from some cancers. And why is that? All the reasons that we just explained, okay? So the first video that I want to show you guys is going to be on breast cancer, specifically for women. And so basically it's a video from the American Cancer Society, and it just kind of gives an overview of breast cancer. It's only 5 minutes. I don't want to lose y'all. It's 5 minutes, but I do have some goodies. I'm going to ask some questions after I'm done. So just please bear with Okay, awesome. See, I told y'all it was only 5 minutes. Okay, so the first question, I want to see if anybody was listening. This may be a little bit tricky, but women should have the opportunity to begin screening as early as 45. You said 40? It's 40. Yes.
The guy was listening.
They were listening. And then the next question is, the next question is going to be, woman with an average risk of breast cancer should begin yearly mammograms by age 45. All right, you got it. Okay, so like we discussed, women should start talking to their doctors around the age of 40 about regular mammograms. If you have a family history of breast cancer, you might need to start even earlier. This is about staying ahead, not being afraid. So I wanted to just point that out. Like one of my best friends, her sister had breast cancer at 32. So even though the average, insurance companies usually won't allow you to test until 40, if there is a family history in it, you can inform your doctor and you will be able to be tested. So I want to let you guys know. So if you have family history, go ahead and, not tested, I'm sorry, go ahead and get screened, okay? Okay, so the next video that I'm going to discuss, or we're going to play today, is on the prostate cancer. So So I just wanted to point out that Black men are the higher risk of prostate cancer and tend to get it at younger ages and at more aggressive stages. We actually were discussing this in the office that there was a patient who was 19 with prostate cancer. So we have to get screened. You guys have to get screened. I wanted to see if you guys are paying attention. So the first question is, on average, how many out of 100 men who are 50 will be diagnosed with prostate cancer? Somebody said it first. Okay. All right. Okay. How many tests are offered for prostate cancer screening? Who said it first? Oh, I don't know. You said it first? What did you like? We'll give it to somebody else. You did it. You said it too? Okay. And this is, I want to see, hold on. Okay, wait, this is about the two. What are the two tests? Yes, sir. Yes, sir. Okay, so like we discussed, Black men should start talking to their doctors about prostate screening around the age of 45 and even early if there's a family history. So don't wait. Ask questions, get tested, get screened, and this could literally save your life, okay? If you haven't been screened yet or you're unsure what you need, now is the time to ask questions. Make a call or go to a friend. You are literally have a village right here. There's no reason why we can't get tested. There are so many resources out there. You have the local health departments. If you go to the local health department and you tell them, I don't have it, they cannot turn you away. They will test you. They will do the screenings. You call around different local health departments, offer different screenings, but they will do the screenings. There's also a website called findhelp.org where they'll offer you resources within your community, so you don't have to go all the way to CAB if you're living in Clayton County, okay? I just wanted to make one big statement because I wanted to go back on the reasons why we don't get screened, right? At the end of the day, you have to be an advocate for yourself, okay? You could say the doctor didn't tell you, you're scared. You have to be an advocate for yourself. My mother had breast cancer. Within the last 2.5 years, she has had a heart transplant, a kidney transplant. She has had her appendix removed. She has had a stroke, and she has had 2 infections, one MRSA and one, I can't remember the other one, I think it starts with a C, in the hospital. And she is still here with us today. Of course, it's the grace of God, but it's also because she advocated for herself. We need doctors, don't get me wrong, but they have hundreds of patients. So you have to advocate for yourself. You have to reach out to your nurses. You have to reach out to your doctors and say, what can I do? What can I eat? What diet can I be on? It's so many different ways to advocate for yourself, and you are responsible for your own health, okay? And there are resources. There is no reason why you cannot get screened. The resources are in your community. You're at church right now. This is a resource for you right now. So I just wanted to end it with that. So thank you. Get screened.
I'd like to try to do a little bit of a question and answer. I'm going to correct one thing you said, though. When we talk about the Tuskegee study, it's not the Tuskegee study. And the reason why I want to tell you that is not the Tuskegee study, because we want to give credit to who the demon is. It is the United States Public Health Service study on untreated syphilis in Black men at Tuskegee. So I don't want to abbreviate that with saying Tuskegee because, first off, we don't want to discredit one of our HBCUs, and we don't want to make people think that it's something particular going on as far as down at Tuskegee. If you have a question or something, please feel free to raise your hand. How many of you, but in Georgia, with the Affordable Care Act, are screenings covered for free? Colon cancer screenings? Yeah, it's probably the same thing for prostate and breast then. How many of you vote? Okay. That's good, and I like to see that. Make sure everybody that you know is out there voting, because one of the things that's being done away with is what? Medicaid? And one of the things that's going to happen as far as Medicaid, there's a fellow named Reed Connolly, who's a judge down in Texas, one of the Trump appointees, who's putting an end to the mandate covering screenings for everybody that's free. And as we look at cutting back on Medicaid, that's one of the first things to go. is this mandate saying everybody gets covered as far as their screening is concerned. When you talk about stages, Dr. King Mullins, what are the stages? I understand that there are 4 stages for colon cancer. Could you briefly just tell us what those are?
All right, yes. So the 4 stages, so the only real difference between stage 1 and 2 is kind of really the size of the tumor as it's related to the colon wall. Once we get up to stage 3, that means we call that a regional disease. That means that now the cancer cells have been able to migrate away from just the colon wall, and it's in the lymph nodes nearby, and that's the first stop before it gets the opportunity to spread to other places in the body. And that's the stage in which we start really discussing things like chemotherapy and stuff like that. And then stage 4 means that it's spread to other areas of the body. So that's what we call metastatic. So the most common distant site of spread is going to be the liver, but it can go to the lung. It actually, in women, they can get what we call a drop metastases, meaning that because of its proximity to the ovaries, it can literally just drop into the ovaries, and now that's also considered stage 4. And so the importance of that, when we kind of just cycle back to early detection, is again your survivability, and as well the aggressive nature of treatments will continue to go up and up and up as we progress into those higher stages.
I have a question for you, and that is, what about getting a colonoscopy? Let's face it, getting a colonoscopy, what? You're getting something to put you to sleep, and somebody takes a long big tube shoving up the back passage. And what about that in a prostate examination? Do you find anything sexual about that?
Not at all. I'm actually, I had a question. I'm actually,
go ahead.
okay, I'm actually.
And the reason I asked that, because that's something people say, and you look like one of these real macho guys with your cowboy hat on. So I just want to make sure. Go ahead, sir.
All right, so I'm Youssef. I'm 46 years old. Last year I was 45. I had my colonoscopy. Can I give it up? Can y'all give it up?
Yes!
I got it done. And I've been getting my prostate checked since I was 40 years old. Same doctor, Dr. Ram. I say, come on, doc, give it to me. And he, does what he do. He take that KY. Y'all know that. I don't want to get too graphic. But no, it's nothing sexual. I care about my health. Like I said, I'm 46 years old, and I think I'm more conscious now, as I get older, and I'm taking care of my body more, things like that. So I had some questions though.
Yeah, go ahead.
All right, so my sister picked me up from my procedure, and I had conversations. Remember, you said family conversations, which are about your health. She told me that she didn't get a colonoscopy, that all she had to do was send her stool to her doctor. And I was, a little confused about that. Like, that's not a procedure. How is that? How is that? When is that done, and is that another way?
Sure.
Okay, he didn't tell you that his sister picked him up in one of those P. Diddy parties. But go ahead. Well, he's the one that mentioned about the KY jelly. It wasn't me. So, okay, so tell us. So now tell us, what is now you made a point about talking about Cologuard. You made a point about talking about the Cologuard. So,
Sure.
Aaron, if you would tell us about that, and then tell us about some of the other tests people can get done.
So I will just say, first and foremost, the best screening test is the one that gets done. Okay, so there are some people that, for various reasons, because again, the colonoscopy is a procedure, and as he mentioned, his sister had to pick him up, and so, sometimes just logistically you can't get it done for whatever reason. So if there's and some people are just like, I don't really care. I am not getting a colonoscopy. What are the alternatives? And so the stool-based test, so she may have sent off, so that there's the Cologuard test that we talk about. That's supposed to help identify abnormal DNA in the stool. It can also detect if there's microscopic blood in the stool. There's some other tests that can test for like the microscopic blood or abnormalities in the bowel movements. But again, the thing is, if those come back abnormal, then the next step is they're going to send you for a colonoscopy. And so, the colonoscopy is being, you can find something abnormal, take care of it right then and there. But also, if the colonoscopy is completely free and clean and normal and you don't have any family history, you're good for about 10 years. I'm going to put an asterisk next to that real quick, but you're good for 10 years. Those other types of screening tests you have to do much, much more frequently. Number two, and this is not, I don't need to know the results of your report, but patients who have a family history of colorectal cancer or polyps are not a candidate for the non-invasive test because there is a higher rate of a false negative, meaning that the tests come back normal, but there is actually something there inside. And so they need to have a colonoscopy if there's any family history. And then the reason I put the asterisk next to the say like, oh, you're good for 10 years, there are some insurance companies that will pay for you to have a screening colonoscopy every 5 years. So if they'll pay for it, get it every 5 years. It does, so don't, so just know what your benefits are and what's available to you. And then lastly, we get people who are hesitant for various reasons, or they have various feelings about different tests. And so you have to meet people where they are. And so I have found my greatest success in not just saying, you got to get this done, or, trying to relate it to something else. I try to relate it to, I ask people, do you have children? Do you have siblings? Do you have parents? Do you have loved ones, right? And they're like, yes. And you would do anything for your child, right? You would do anything for your brother and sister. You would jump in front of a train, you would catch them from the jaws of death. So why not live for them? Okay? Don't put them through unnecessary trauma and strife that can be avoided and then also just knowing what their risk is. If you have a child or something and you've been diagnosed with a cancer or a polyp or something like that, wouldn't you want to know if they're at increased risk so they can go get tested so they can live more fully? And so I want us to not always approach this in a manner of avoiding death, but also just prolonging and advancing life.
Imanja, would you please tell us, when we talk about the family history, we talk about family members, what are we talking about? Is that parents, grandparents, cousins, second cousins? Because, sometimes we get third, fourth cousins and all that sort of thing. Is that family history?
Oh, sorry. So, like the gentleman even said, it can be parents and it can be siblings. Like I was telling you guys before, my best friend's sister was diagnosed with breast cancer, and she did get approved to get screened for breast cancer at the age of 30. So it is that immediate family that it gives you that reason to go get screened.
We have a question back here. Stand up, please, sir.
Yeah, my name is Alan Dawkins. I'm a veteran, so I'm 65 years old. I'll be 66 in about 10 more days.
Happy birthday.
Thanks. Every 6 months, at my primary at the VA, I get my checkup and I get the blood test. But 2 years ago, I got my colonoscopy. And just to let you know, I didn't even, they put you under. So, when I woke up, it was over. And my daughter was there to pick. They just asked you to have somebody come pick you up to drive you because they said sedate you. So there's really you don't feel nothing. So I'm just saying, everything is just in and out. It's out. You're out there.
Yeah. And thanks for sharing that.
Thank you very much.
And let me just add on to that, the importance of a primary care physician or doctor or provider. How many of you see your primary care doctors on a regular basis? At least annually. At least annually. And if you have other medical conditions, they may need to see you, quarterly or biannually or whatever. But while you have to advocate for yourself, if you have a good relationship with a good primary care physician, they can help advocate for you too. Why? Because if they see you every year, they see your weight, your blood pressure, your labs, and all that stuff every year. If you show up and something's a little bit out of whack, they will know, is that really out of whack or not? And I'll give you a prime example. So all these labs that we get, there's a range of normal. So there's the low side and the high side, right? So if you go to a primary care doctor every year and your, PSA level is normal, but on the low side of normal, and then all of a sudden the next year you show up somewhere and it's the high side of normal. If you had never had that primary care doctor and you went to the hospital with complaints and they did labs and all your labs were normal, they'd be like, you're fine, you're normal, no problem, right? But if you've been seeing a primary care doctor and now all of a sudden your number is 6 when it's usually 3, even though it's still normal, that's abnormal for you. And that requires further examination. So even if you're feeling fine or whatever, there's still the importance to going to see that primary care physician so you know your general state of health. So if something gets even slightly out of whack, that might cause pause and warrant much, much more investigation than you think it should.
Imanja, could you tell me, do you have to go to your primary care physician to get scheduled for a mammogram or even getting blood tests or whatever for a prostate exam, or can you order it? Can you yourself say, "Hey, I want to get this"?
So,
done?
like I was telling you, you guys can go to, technically, it is best to go to your primary care provider. Like she just said, they have a record. They'll be able to keep a record of your past visits and see what's abnormal and what's normal, right? But of course, we know that sometimes that may not be possible. And so like I was saying before, that is the reason why we have health departments. There's different organizations that offer those tests as well. Of course, it's going to always be best to go to your primary care provider. But like I was telling you, sometimes you may not have the resources, you may not have the insurance, and that's where those public health departments come in play. Or like I was telling you guys about findhelp.org, it's a lot of organizations that offer those those screenings at reduced or no cost.
We have a question here.
Concur on the colonoscopy, 56, and I had my second one. And I say I do all the screenings because my 24-year-old was diagnosed with ALL at 6. Now he's cancer-free, thank God, 18 years. However, that's one of the reasons why I do all the screenings even before I just asked for it, advocating for it. But my question is, since he's 24, I remember them saying other cancers could. I'm not claiming that at all, but when should he start the screenings, like for the prostate and for the other things?
And really, to be more specific, which cancers tend to run together in families, and which are the ones, and if it's there in the family, do you start doing it? So we said 45 for colon, but if you got a family member that is 45 when they had their cancer, when would you start doing that screening? Thank you very much.
Yeah, sure. So thank you for those questions. So the ALL is acute lymphocytic leukemia, for those who don't know, and that's a blood-based cancer, like a leukemia, lymphoma, and all of those things. There's no real direct kind of correlation to colorectal cancer per se. However, because that is an impact on the immune system, so your body's immune system actually plays a huge role in help fighting off cancers. And so I would just see whether or not your providers will cover it, as a high-risk examination, and sometimes they'll go ahead and cover it. So I don't think it would be harmful. There's no glaring risk based on the ALL, but there would be a slight elevated risk likely just because of depending on how long he had it, how many, and you said right? A son? Okay, sorry, yeah. How long, he was battling with it and how long he may have been on immunosuppressive therapies and all those types of things. And so it is going to vary from person to person. The other thing that you could always do is I very often refer patients to genetic counseling because, again, there are certain groupings of other hereditary diseases. So if a gentleman comes in my office, he may be only 40, but I look at his medical history on the chart and family history, and he's had 5 women in his family with breast cancer. That's going to actually pique my ear to say, you probably need your colon cancer screening early because breast cancer, prostate, pancreatic, kidney cancers, all of those, and then there was another blank, like ovarian cancer and all of those things. There's certain hereditary syndromes that can link those things together. And so when I start seeing those different cancers across a family, I will recommend genetic counseling to a patient, and that's very different from genetic testing. Genetic counseling You actually initially have a conversation with a trained genetic counselor, and they help you go through your family tree. So who had what at what age, and then if there's certain red flags, they will recommend, say, you know, you really are at risk for this certain genetic problem, and so we should test you. And you decide if you want to pursue the blood testing. But the importance of that is, again, if there's something that runs in the family, you know, it may be that you folks need to get tested for pancreas and ovary and kidney and thyroid and so many different things. So having that's the other point, again, of having a primary care physician when you're going every year. When they ask you if there's any update to your history, if there's an update to your family history, that's also important. So you may have not seen your primary care doctor in 2 years because last year you were out helping your mom take care of her breast cancer diagnosis. That was never on your family history list for your primary care doctor because that's a new thing. So you have to make sure you update that family history with them as well.
I apologize. I know there are a couple of more questions that people have. Most of us will be around for a little while to answer some more questions, but we have to move on to the next part. And I apologize, but we will be here to tackle some more of the questions that you all have. And again, I apologize. How about giving a hand, though, to our speakers? Thank you both very much. I'll be around. Imanjo will be around. Imanjo will be around. I think Dr. King Mullins may have to run, but I think I'll be able to handle some of the questions people may ask. So please, if you'll bear with us after the next part of the program, we'll still be here to talk about things. Thank you very much. I'd like to bring up our next speaker, who is Ms. Vernette Cheeks. Ms. Cheeks is a nutritionist with the DeKalb County Board of Health. She earned her BS in biology and got a master's degree in nutritional science at the South Carolina State University. In addition to her numerous speaking engagements, she is also the CEO and manager of Healthy Eating and Living, LLC. Ms. Cheeks will demonstrate some cooking techniques that maintain nutritional value inherent in the food itself while still maintaining our ethnic cuisine. Ms. Cheeks. Just step down. Let me see about that. I may point out, when we talk about certain cancers, by the way, breast, prostate, colorectal, uterine, ovarian, you can also add pancreatic, renal, and bladder cancer. These tend to run together in families. So if you've got one or more family members with that, it increases your risk for developing, say, a colon cancer or an ovarian cancer. Yes. Oh, wait a minute, here she comes with this stuff. Yes, sir, while they're setting up. Thank you for mentioning that. That was one of the things we were going to talk about. Yes, breast cancer does occur in men. And if you remember Richard Roundtree, shaft, breast cancer. So even though we mentioned a lot about women, it can happen in women and men also. So please, thank you very much, sir. Move this out the way. While we're getting set up for the cooking demonstration, I want to remind you again about the surveys. If you would be sure to fill those out. And while I'm waiting, let's see. Maybe we'll take the young lady I was going. But sir, you had a question. What was your question going to be? Maybe while we're waiting, go ahead. You had a question you wanted to ask?
Yeah, first say, I'm currently a cancer patient.
Mm-hmm.
I'm going into my 12th round of chemo right now. So I don't look like what I've been through. I have colon cancer.
Mm-hmm.
So the question that I have for you, how does stress play into that?
That's a very good question. When we think about things that risk factors for development of colon cancer, I think you recall that Dr. Mullen said that about 15 to 20% of the time is related to genetics. 80% of the time it's been what we would say has been spontaneous. In other words, there's no obvious factor, of which the number one factor is diet. Things that we're taking in, foods that we eat. So I know everybody loves to have their barbecue. This is that time of year, isn't it? And you love to get that little char on there, and you get that stuff. That's called heterocyclic amines. That's a cancer-causing agent. You get a lot of foods that are fatty in nature, get increased production of bile to break down the fat, which breaks down into secondary biliary acids. Guess what? Also cancer-related. So and then when you talk about stress, we do know that stress plays a role in development of colon cancer and other cancers, because one of the things that happens with stress, it causes an increased production of catecholamines and other corticosteroids, which decrease the body's immune system, which means you're now, one of the things that helps as far as fighting cancers, you see a lot of new cancer drugs, they stimulate the immune system to fight off these cancers. But what happens now, you're having a decrease in your body's ability to fight these things off, which is leading to some of the things. So we know that stress does play a role in the development of colon cancer. So yes, sir, you're absolutely correct. So there are a lot of different factors. And I also might point out environment. If you look at one of the things that we see with the decreasing age as far as, come on up. And one of the things we see with the decreasing age for colon cancer, a lot of it has to do with environmental stimulants. A lot of that has to do with things we're taking in from those things. All right. Just about there. You ready? You ready? All right, I'm going to turn things over. I'm going to get out the way. I don't need to do the introduction again, do I, Ms. Cheeks? You straight, darn there. All right. Ms. Cheeks going to make sure we eat right. Let's go ahead.
Ms. Cheeks, you need a mic?
Yes. Would you like one with this hand here?
Ms. Cheeks, you need a mic? I'm going to turn this around too as well, okay?
Well, good afternoon, everyone. Good afternoon. I'm Bernette Cheeks, nutritionist, and okay. Well, I am the DeKalb County Board of Health, but today I'm healthy eating and lifestyle, and so this is my street ministry. Okay. Okay, all right. And so in the clinic, you know, you're bound with seeing a patient in 15 minutes, and that's doing labs and seeing the patient and all the paperwork. And so you have about 2 minutes to talk to the patient. And so healthy eating and lifestyles connection is a way for me to bring the clinic to the street. And so I thank you all, Heal Collaborative, for the invitation today. And a lot has been said already. He spoke already about how stress affects our immune system, and all of that can lead to cancer and can help trigger cancer, can help aggravate cancer. And so my job today was, I do have a presentation, but a lot has already been said of what's in my presentation. So basically, we do want to recognize that food is medicine, okay? That's coming on the scene a little more prevalently, well, a lot more prevalently now than before. I heard one doctor say just this past week that they're trained to, in all of those years of medical training, they only get like a week or so of nutrition. And so a lot of doctors have started going out on their own and learning on their own and learning the importance of food in health, in treating our health. And so, next slide, please. Okay. Hippocrates said, let food be thy medicine and medicine be thy food. And so, I don't know if let food be thy medicine. We're going to stick with that one, okay? Because, yeah, we want to start there. It's something we do every day, okay? It's something we do every day. I talk loud, so, okay? But I love nutrition because it is something we do every day and something we encounter every day. And so we can start there. I've heard even doctors say that a lot of patients would need to be in their office if they just ate better, okay? So if we watch what's on our plate. But in addition to watching what's on our plate, as the doctor just said, stress, so making sure we're getting good sleep, and making sure we're getting some movement in their physical activity, all of that's important. But we want to let food be our medicine because it's important in the prevention and treatment of disease. Next slide, okay? You can go on, okay? You can go on. So eating and drinking healthy foods and drinks in the proper amount, again, helps our bodies to function properly. And so we've got the farmer's market out there to help us to get a lot of the foods that are considered anti-cancer or can help in the treatment of cancer for someone maybe that's going through treatment or someone that's trying to, or all of us are trying to prevent, because cancer is just widespread now. It doesn't discriminate at all. So it's just widespread. And so healthy eating and living can help us to promote our health, help our bodies to function properly, and help us to be in health as our Maker intended us to be. Next slide, please. Okay, you can move on. Next slide. So research has shown that a mostly plant-based diet aids in the prevention or the reversing and the prevention of a number of diseases. And so plant-based diets basically veggies are vegetables, fruits, beans, legumes, nuts, seeds, whole grains. And if you desire a minimal amount of lean meat, fish, turkey, chicken, poultry, and a little low moisture cheeses and a small amounts of dairy products can be added as well. Okay? Certain chronic diseases are associated with unhealthy diets. Type 2 diabetes, I'm sure we've covered a lot of this, cardiovascular diseases, obesity, and a lot of these run in conjunction with cancer. So we want to pay attention to all of that because as an ethnic group, we tend to be higher, and research shows that we are higher than almost all ethnic groups in almost every disease category. So again, we want to pay attention to what's on our plates. So certain cancers, autoimmune diseases, kidney health, brain dysfunction, eye health even, all of that we can we can tweak our diets a little bit and affect our health in all of these areas. Okay, so this is where most of us are, not just our children. A lot of us too, adults, okay? So this is where we are. We're leading ourselves to a much earlier, to sickness and to death, a lot earlier than we need to, okay? So we're doing this to ourselves a lot of times. So we want to make sure, again, that we make some tiny changes in our diets, make small changes in our diets so that we prevent this. We prevent it, we stall it, we want to prevent it, okay? Because, and our children, like it says, our children are getting diabetes now. 4-year-olds with diabetes, 4-year-olds with joint problems, okay? And so we want to ward all of that off. So we want to help, our children are learning, I work in WIC, with the DeKalb County Board of Health, I work in WIC, and that's age 0 through 5. And so I try to get the parents to understand you're forming their eating habits right now. So don't let them eat all that junk. You know, parents will sit there, what do you want today? What you want to eat today? What's the child going to say? McDonald's. Exactly, you know. So, no, you make the decision. Well, there is a thought out there that you provide the food and you let the child decide how much he will eat. But again, you know, a lot of times they don't want what you provide. They don't want the healthy vegetables. They don't want the broccoli trees. They will eat the fruit, but they don't want the broccoli trees. They don't want the spinach. They may eat a little carrots, but they basic corn, green beans, potatoes. okay? Those are the 3 that they may eat if they're eating vegetables. So even when we have farmers market in the clinic, I stress eating from the colors of the rainbow, okay? The different colors of foods, as the gentleman was saying, provide different nutrients, different antioxidants, and different nutrients. And so we want to make sure we're eating from the colors of the rainbow more than just the corn, carrots, and potatoes, or the green beans and potatoes. And so actually, green beans actually don't give us a whole lot of nutrients. Green beans give us a little bit of fiber, and that's about it. So with green beans, I throw in some red peppers, some asparagus, some carrots, throw in something to give them a little boost. But alone, they don't do a whole lot, okay? So we want to make sure that we're making choices to help us prevent overweight and obesity, or help steer us away from those and the type 2 diabetes. Next slide. Okay. Again, all of these conditions can be reversed by tweaking our diets, okay? Next slide. So this is kind of where we want to get to today. The Mediterranean Eating Plan have shown that reversal of metabolic syndrome, diabetes, heart disease, certain cancers, and obesities can be accomplished by eating, again, us tweaking our diets. And so what we've presented here today is a little bit of the Mediterranean Eating Plan. And so I know that time is short here. Wait, my watch gave out on me. Okay. Time is short here. And so what I've done, what we've been asked to do is to provide a food demonstration. So we have some of the plant-based foods. We have a little, and it's a taste test. And so, because I didn't think, we had time to sit and eat. Again, we're at the end and time is short, so it's a taste test here. So I'm actually going to ask a few people to come up and test it out, if you will. But we have some quinoa here. Usually, when we ask people about whole grains, brown rice, wheat bread, oatmeal, okay? But there's a whole nother world of whole grains out there, okay? So quinoa, farro, spelt, amaranth, steel cut, oats, rolled oats. So we want to make sure we're getting some of these in our diets as well, okay? But by all means, continue with the whole wheat bread or your multigrain breads. If you're allergic to wheat, multigrain bread is fine. So even rye, just a variety of multigrain breads. Just make sure that you're reading food labels, okay? That's the big thing. Make sure that you're reading food labels. You've got your glasses on. You've got a magnifying glass, okay? Some of us need a magnifying glass to read some of those labels, especially. Are you pulling my coattail?
No, don't worry. No, while you're talking and get ready to do that, I think there are a couple of points that if you would make sure you touch upon. So yes, in a little bit I'm pulling your coattail, but more importantly, if you would talk about one of the things which we mentioned early on in the program, we all eat greens, but we beat the devil out of the greens. When we're cooking. So give us an idea about that. And also, because the incidence of diabetes and obesity is so high in the African American community right now, what are some of the things we have to be cognizant of so that we're getting in lots of fruits and vegetables, but yet how do you feel as far as making the diabetes problem, the sugar problem, a little worse? So those two things, as you're talking about what you're doing right now.
Okay, all right. Well, like you said, the same goes. There are a few whole grains that we stress. There are a few greens that we stress. Collard greens, the broccoli trees, cabbage maybe, and the turnip greens. So in the green family. Today we have some Swiss chard, okay? And so it's a wilted green as well, and it falls in the same category. And so it does some of the same things. So just when I go to the farmer's market, even when I go to Kroger, I'm like a child in the candy store when I see all those beautiful fruits and vegetables, the vegetables mainly. when I see the beautiful colors of vegetables and the different variety there. So some bok choy, sorry about that. Some bok choy, we want to make sure we're including that in our diets, even the Napa cabbage. Again, we have Swiss chard here, and you can get Swiss chard green or you can get the red. This one is mostly green, but it does have red. It has red stems, so we've got a little bit of the red stems in our chicken here. I did include some chicken. So we've got lentils, which is, as we said, that's part of our protein. So lentils, legumes. So we've got a little lentils here. We've got quinoa. We've got our greens. We've got some spinach and broccoli in there. But I wanted to throw that Swiss chard in there because, again, that's something that a lot of us kind of even when my husband saw it, he's like, I'm not eating that. So that's one that we don't gravitate towards. So I kind of wanted to throw that in. And it's just wilted. It's not fully cooked. You can cook it like you do your collard greens. But today, this was kind of a rice bowl or a quinoa bowl. And so it's just wilted, okay? And so we've got some chicken, teriyaki chicken here with a little apple and apples and grapes in it, okay? And then we have our village salad, pretty much, with mixed greens. We have we have the arugula, and we have a spring mix here, spinach, again, I love spinach, and we have green leaf. So we want to make sure that we're kind of that we are steering away from the iceberg, okay? Yeah, okay, right. We want to steer away from the iceberg. It doesn't have any nutrition too much in it, okay? I'm a little cautious of romaine a lot of times because it's on recall a lot of times, okay? So I kind of steer away from that. But again, make sure we're getting our mixed greens in because, again, the different colors of vegetables, this is supporting your immune system. This is helping build calcium, iron. It's a variety of nutrients here, your vitamin C. So we want to make sure we're getting those in. We've got some bell peppers here, some olives. Again, olives and feta cheese are big in the Mediterranean diets. And so we have a little of that here. And then, of course, we have our fruits. I don't think I need to talk a whole lot about that. We have some tomatoes here. Tomatoes have the lycopene to help fight cancer. So we have some almonds here. Almonds are one of those nuts that help fight inflammation. And inflammation is big. A lot of doctors believe that inflammation is at the base of almost every condition that we suffer now. And so the diabetes, our heart diseases, all of the arthritis and everything. So if we can get a handle on that, we can get a handle on a lot of the conditions that we're suffering. And so America is full of sugar. We're constipated. And we're full of inflammation. So again, if we can make a few little tweaks in our diets, we can take care of a lot of that. We can lessen a lot of those problems. And so that pretty much kind of sums up a lot of what else is in my presentation. I'm sorry, I missed that slide there about the standard American diet, the SAD diet. Right, the SAD diet. So we want to start, again, making some changes, okay? And that's another reason why I kind of veered out with healthy eating and lifestyles, because I don't want to adhere too much to that SAD diet, okay? Now that I know better, I don't want to stick with that SAD diet. And so a lot of things that we're eating, I'm sure we've covered the red meats, the processed meats. A lot of these things we're eating, they're not helping our health. They're harming us. So foods can help and foods can harm. And so the processed meats, the red meats, big dairy, big beef, big agriculture, you know, all of those support the American Dietetic Association and the American way of eating. And so we want to, again, as we learn better, we want to do better. So we want to, again, go with lean cuts of protein, lean cuts of fish, poultry, eggs, turkey, some red meats, some red meats, but minimal amount. Okay? All right. And that pretty much, there's more here, but that pretty much covers the presentation. Again, I know we're strapped for time, and so I thank you all, and I think we'll have some questions later on. And so,
Well, thank you very much. I appreciate that.
you're welcome.
Do you mind that after the conclusion of the program, people come up and have a chance to do some of the sampling? All right. Well, again, let's give a hand. And I think the most important thing when we look about, to be quite honest about it, the most important thing in terms of our discussion today was what Ms. Cheeks was talking about. Because when we look at some of the problems that we're having, as far as the earlier onset of chronic illnesses that are occurring in African Americans, a lot of it does have to do with dietary things. And I think the key point that she raised was about the inflammation. And there's so many things that give rise to inflammation. We were talking about things that give rise, stress as related to colon cancer. Well, stress, again, we talked about increasing the immune response, or decreasing rather the immune response. But also when we look at environmental things, something called PM 2.5, which is parts per million, less than 2.5 microns in size. It's something that's less than the size of a human hair. And the problem with that is it stimulates inflammatory responses. And we find this in areas where you have high loads of truck traffic, mining, air pollution. And when you put that together, stimulating inflammation, then some of the foods that we're eating, particularly, as Ms. Cheeks pointed out, the highly processed foods, they do stimulate inflammatory responses, which give rise to more problems as far as the arthritis, but again, the cancer thing. So I think the most important thing, and I love the way you had that, food as medicine, because that is the way we have to look at it. But the problem comes down is many of us live in food deserts. And then again, it gets down to the thing. You notice how she avoided talking about how to cook the greens, but that's all right. We're going to get back to that before she goes. But again, how we are cooking things, and there are things that we pass down from generation to generation about how we do it. We need to start passing down some good habits. Not saying we can't have stuff like we, go back and have it, but we can't do it every day. What I'd like to, no, you get you in a minute, because otherwise they're going to fuss at me some more. That's all. What I'd like to do, first I'd like to thank everyone for being here today. Again, if you have not filled the second part of the survey, please fill it out, and then you can leave it with us at the end. I'm going to bring up Stan. Did you want to come back? Or you through, man? Because otherwise we'll bring back then Deacon Cuffey, and he will close this out. And don't forget, before you go, there is the farmer's market, which is out here. So please make sure you pick up your produce, and it does color the rainbow. And then if you have some more questions for any of the other speakers, please feel free. I'm first.
Well, on behalf of Dr. Kevin B. Lee and the entire Berean family, can you give yourself another hand clap? Phenomenal. The fact that you stuck it out. We are honored to have hosted you today. Hopefully you've heard something that will be a blessing to you both now. And again, I mentioned my great friends at Gwinnett County are here with Live Healthy. How about that? So we want to continue to network amongst each other. My dear friend Alita Sims in the back there, who is a phenomenal woman of God and who does a lot. I've learned a lot. And again, we love you. We appreciate you here, Berean. You're always welcome to come out and join us. We have an 8, a 10, and a 12:30 service on Sundays. God bless you. We love you, and keep it moving. All right, Deacon Watson, did you?
All right, Terry, you want to say anything? Come on.
I just want to thank everybody for coming out, and please take the produce. We have so much out there for you. There are bags out there. Please take it. If you don't want it, take it to a neighbor, to a friend, a family member.
All right, thank you for sticking with us. If you hear about HEAL doing some other things in our community, please come with us. Again, let's give Pastor Lee and Deacon Cuffey a hand for hosting us today. Let's give our moderator, Dr. Tuxton, a hand. Came all the way from Kentucky. Appreciate you as well. Let's go home. Gracious God, our Father, we thank you for this day. We thank you, God, for what our eyes have seen and our ears have heard. We ask as a community, God, that we don't only not be hearers of the word, but we continue to be doers of the words in our community. Now, God, give us traveling grace and arriving mercy as we go to our respective homes, prepare our hearts for the word on tomorrow. And God, give us the things that we need that we're having voids of right now. We pray this prayer in the name of your Son, Jesus Christ, and for his sake we pray. Amen.